So this one, I think we've got another poll, so hopefully Becky can put that up. And it's just going to give me a question as to what it kind of is going to be very related to what you actually think the problem is on this one. So I'm going to work through it and then we'll try and figure out what it is together. So we have a non-contrast CT. I can see it's a non-contrast CT because the aorta doesn't have any contrast within it and it looks very much the same density as everything else around it. And if it was an aortic image, aortic phase image, then you'd see a very high density aorta compared to the bone, but you can't see that. So that's a non-contrast study, and I think therefore this is probably going to be for a CTKB. So let's have a look at these kidneys, see what's going on. So you've got kidney there, kidney. I mean, you've got kidney there and kidney there, and you've got these sort of spherical lesions located there. These are most likely to be multiple renal cysts, and there's multiple of these renal cysts on both sides. This one maybe look a little bit dense, so might suggest if they've not had one before, do an ultrasound, have a closer look. Now, when you look at the renal hilum, which are these areas over here and here, they look very, very fatty, and they wouldn't look fatty if they were inflamed or they were blocked, because then the ureter would take up most of that space. But the ureters don't look blocked at all. And then let's go stick on the right side and try and see if we can find the ureter. So that's the ureter, I think, there. Let's try and follow it down. And this does take a bit of practice. And over time, what you notice is that your eyes just sort of almost kind of assume you know where it's going to go. Like I know that's probably going to be somewhere here. And if you ever get lost, my big recommendation is go from the bottom. So it's going to be the vesicular ureteric junction. You're coming up, you can see that ureter that way. You can see that ureter coming around there, coming around there, coming around there, and it all looks very, very thin. I haven't seen any calculi whatsoever. So then we go to this next one and see this ureter go all the way down, all the way down, all the way down, all the way down. Okay, it looks like people knows what this is, so I'll go quickly. And you can see the vesicular ureteric junction looks okay. Now, one last thing I'd say is always go a bit further down just to be sure that there's no calculus sitting within the, the prostatic urethra, within the bulbous urethra. That does happen where the calculus is actually still on its way out. We've just managed to catch it. I've seen a few cases like that. But anyway, I don't think this can be a kidney problem. And then let's have a look at the gallbladder. Gallbladder's here. It doesn't look particularly bad. It looks like it's pretty thin-walled. And now we've got to look at the pancreas. And so the pancreas is over here. And if you look at the pancreas over this area over here, it looks okay. But around this middle area, can you see that? It starts to look a little bit, it's a very, very slightly fat. Okay? It looks very slightly fat. And around it, there's a lot of fat stranding. Like if you look at the fat over here, so let's do that. Fat over there compared to the fat over there, right? So that fat looks slightly fat stranded. And you come further down, there does look like there's a little bit of fluid that's emanating from that going downwards. So on balance, when you look at that, you think to yourself, okay, the kidneys look okay. They've got this abdominal pain. They've probably got examined. Someone thought it's right or left-sided. But actually what's going on is most likely, and actually when you zoom in, let's zoom in a bit so we can all show each other. So let's go to zoom, zoom. Yeah, it's all around this pancreas, like there. So this is going to be pancreatitis. And so the question I put to you guys is actually a question based on what you think the diagnosis is. And so, oh yeah, so let's do that. Let's go reset all. I said is a bowel ischemia. So it's probably quite important that we do look at the bowel since I've brought that up. So bowel ischemia, let's have a look at the bowel. So you always go from the bottom, go all the way along like this, sigmoid colon, all the way along like so, all the way along like so. And then if you ever get lost, my constants are always going to be the descending colon and the ascending colon. The sigmoid colon can move around a lot, and the transverse colon can move around a lot, but these two are normally generally quite stable. So if you ever unsure where to go, start from the descending or the ascending and work your way back again. You can see the bowel going this way, going this way, going this way, and then down this way, and it all looks okay. Can we find the appendix? Maybe somewhere there. Maybe it doesn't look inflamed though. It doesn't look like there's anything going on there. So there's no bowel perforation. We've ruled out appendicitis. There's no ischemia from what we can see. So therefore, we say this is a pancreatitis. One of the complications of pancreatitis is splenic vein thrombosis, because that's a splenic vein over here. And because it's so close to the pancreatitis or to the action, that can result in sort of a prothrombotic situation where you end up getting a thrombosis within that region. And over time, you can actually get splenic artery aneurysms as well. You can get collections over time. So those are all things to do with pancreatitis that I would, in my report, I always try and like write that because someone said uncomplicated oh, do you say diverticulosis? Oh yeah, diverticulosis. Yeah, fine. That can be quite common. You can get diverticulosis. Yeah, that's like these tiny little outpouchings in the bowel, but they don't look inflamed. Interestingly, they do actually have these kind of inguinal hernias, which can contain a little bit of fat, I think mostly on the left side. But otherwise, yeah, In my conclusion, I would say non-contrast study, limited non-contrast study, no kidney abnormalities, but there is some faint fat stranding around the spleen, the pancreas. This would be acute with pancreatitis, correlated with the amylase. No secondary complication has been identified on the study. If there's any clear concern, I would recommend doing a contrast enhanced study because on a non-contrast study, it's going to be very, very difficult to be able to see or say whether this person's got a splenic vein thrombosis or anything else going on anywhere else. But anyway, I thought that was quite an interesting case. Let's end the poll and then we can share the poll. I think we're sharing. And you can see that actually most people, yeah, went for it. They kind of got it straight away that this is underlying pancreatitis.